I'm Baylee Seitz, and good morning, and thank you for being here today. I am presenting my Doctor of Nursing Practice project titled Stepping In with Stepping On, which is where I evaluated a community-based fall prevention program here in rural Montana, and that program is called Stepping On. I would like to acknowledge and thank my committee chair, Maria Snell, my committee narrator of Orlando Mullet, and my community help, Dr. Annie Brown, for all of the help and support that they've given me throughout this project, and I could not have done it without them. And so, a little background on falls. So falls remain one of the leading causes of morbidity and mortality among older adults. Falls account for over 3 million ER visits each year and cost the U.S. healthcare system billions annually. In Montana alone, 54% of our traumas are falls, with a large majority of those falls being in people over the age of 55. Stepping On is an evidence-based fall prevention program that integrates interdisciplinary education with the goal of reducing falls. That's kind of their overall goal. Education includes exercise, behavioral changes, environmental modification, medication management, and then peer discussions that help reduce falls, as well as promoting independence in community-dwelling adults. For my review of the literature, I looked over 13 studies, and they were reviewed using Ovid synthesis as well as an AI program called Elicit. There were some common findings throughout the literature regarding fall prevention programs, especially community-based fall prevention programs. These themes included reduction in fall incidents, following a structured fall prevention intervention, improved balance, confidence, exercise behaviors, as well as promotion of independence. Some of the strengths that I found throughout the literature, regarding fall prevention programs is there's consistent positive outcomes in these community-based programs. They generally contain a strong internal valid tool, and then a structured curriculum is going to have the more benefits, so kind of the more bang for your buck in fall prevention within the community. Some weaknesses is a lot of these program participants are Caucasian women. There's limited long-term follow-up. Even Stepping On itself does have a 3-month follow-up, but generally the actual participation in that follow-up is pretty low. And then there's a big heavy reliance on self-reported tools. There's not a ton of objective data measured in this. A lot of it is kind of perception of self, which can have its own bias and is very dependent on participants' ability to recall. Participant engagement and sustainability in programs follow a standardized curricula such as Stepping On is another strength, positivity I found within the literature review. Perfect. And then moving on to the theoretical framework. So I used Roy's adaptation model, which includes psychological self-concept, role function, and interdependence, and how so this looks at how one is able to adapt to their surroundings. And it's harder to adapt not necessarily even like the older we get, but the more we get set in our ways, the more of a routine we have down, it's harder to change. And so using this change model for participants included actual physical and physiological change, such as providing balance and strength exercises throughout the program and seeing how participants get stronger. Education about their physiological changes, such as decrease in vision ability, and the importance of seeing their eye doctor annually to help prevent falls, as well as a medication review and just a discussion on polypharmacy and how working with their primary care provider can help prevent falls, just in the sense of reviewing their medications, talking about what they need to be on, what they need to be on, what can maybe be adjusted, and even what time we can take these medications and how that change can help prevent falls. We looked at the self-concept model, where the fear of falling can erode somebody's independence. If somebody is so afraid of falling that they're not leaving their home, they're not going to the grocery store, they don't go out in certain weather, can be very impactful on somebody's kind of overall health and even their safety, becoming too reclusive. And so stepping on helps participants kind of rebuild and reframe their mindset to adapt to their own abilities. It also provides some confidence in themselves and how they could manipulate their environment to get around safely. Role function is reviewed as encouraging these older adults to maintain that independence, maintain their social and familial and community roles by preventing falls. And then having this independence helps them kind of maintain roles that they've already developed over decades. And then our interdependence adaptation model is going to look at how these are group-based sessions that foster some peer support. And so part of that peer that was really exciting to see was kind of like a collaboration of ideas, where there were participants who hadn't traveled in years because they were so afraid of falling or they couldn't make it across the airport to catch a flight, where others would provide their travel experiences and what they've done, where they got certain suitcases, or they always check their bag, or they use this airport compared to this other airport because it's easier to get around, and kind of that sharing of ideas, and again that support of like, hey, I'm in your shoes. We have similar abilities in our bodies, and this even reduced loneliness among participants and also kind of created some connections that they can carry on outside of this program and develop some relationships there. And so methodology, so this was a quantitative, pre-post, non-experimental quality improvement design using the PDSA model. So first was my plan. What do I want to do? So I identified falls as kind of a priority public health issue, especially in our geriatric population, looking back to the high rates of falls in Montana, especially in those over 55. And then I selected the Stepping On program as it's already being implemented here in the community that I live in Montana, as well as with Cascade County. And then I wanted to see how impactful this program is and if it would be possible to implement into some of our more rural communities. For doing so, analyze the 7-week course. So Stepping On is pretty rigorous in how the courses ran, which made evaluating it helpful on my end, because a lot of the planning, questioning is already done by the program itself. And then studying, so collected pre and post program data, which uses a standardized questionnaire, again developed by the Stepping On program, that has been validated, and then has an assessment tool that looks at a plethora of things. It looks at fall history, fall characteristics of those falls. It looks at a self-efficacy, or how confident they feel in themselves regarding their own fall safety, as well as reported loneliness and their overall fall behaviors. And then analyze these results to provide recommendations for sustainability as well as any possible refinement. And then this was analyzed using a Wilcoxon signed reg test. Because of the low sample size, I utilized the Wilcoxon's test, as well as it's allowed me to compare two groups of information. And so my sample was in a rural Montana community. For Montana, we're pretty large, but there's only about 50,000 people who live here. The inclusion criteria for stepping on is created for their national team. So it's going to be 60 and older, community dwelling adults, so they're not somebody who lives within like an assisted living facility or a specialized nursing facility. That is an exclusion. No history of dementia or cognitive decline. Able to ambulate independently, and this can or can be without an assisted device. Where this program takes place is on the second floor of the aging services. And so part of the inclusion was, can they make it up those stairs to the second floor? There is a chairlift, but many of them wanted to use the stairs. Inclusion was also that they attended the 7-week course with the first week and the 7th week. That's when those questionnaires were handed out. And then exclusion, history of dementia or any cognitive decline if they lived again in that assisted living facilities. Due to not having a translator, they needed to be English speaking. And then if they missed either week 1 or week 7, they were excluded just because that's when we did the questionnaires. There was a total of 15 who were enrolled. There's a few limitations, right? Weather postponed some of our classes, and so participants were no longer able to attend the final 2 because of rescheduling conflicts, rural barriers such as transportation, so people not able to make it all the way into town. All in all, 6 participants completed both the pre and post intervention questionnaire. Of the 6, they were all Caucasian and 4 were female. So my sample was rather homogeneous, which again is why we used that Wilcoxon sign test. And so for data, so descriptive results of participants, we looked at my gender distribution, which was mostly women. 2/3 were women. Their fall history trends, so this included if they've had a fall, where they fell, if it resulted in an injury, and if they sought medical help. And then they'd kind of give me a dialogue of what happened. And then we also looked at self-efficacy and their fear of falling. And then the Wilcoxon's signed rank test compared my pre and post intervention questionnaire results, again due to my data being ordinal, the small sample size. I needed a non-paradigmatic test that was appropriate for my paired samples. And so this test then analyzed their reported fear of falling, the reported self-efficacy, which was using like a Likert scale, and then the behavioral changes. And so the behavioral changes were given either yes or no, so 1 point for no, this change wasn't made, 2 points for this change was made, and then their fear of falling again was on a Likert scale, which then we were able to use the Wilcoxon's test for that. And here are the results. So for the evaluation of the data was again done using the Wilcoxon sign rank test that was completed on 3 sections of this questionnaire: the reported self-efficacy, or in other words, self-confidence, their fear of falling, and then the fall behavior adaptions, or the FAB is also what it is called. Each section ended up with a negative z-score, which showed favorable outcomes. And so this was clinically significant. Right? There was a reduction in fear of falling, there was an improvement in confidence, and an improvement in the fall behavior modifications compared to the beginning of this project. The sample size was rather small, with only 6 individuals. And so my p-value for each section was greater than 0.05, telling me that there's no statistical significance with this. And so a larger group size could possibly make this more statistically significant, but there was clinical significance with improvement in the areas that we were hoping to see improvement for the participants. And so limitations, a major limitation was that there was only 6. The sample size was also rather homogeneous, with a vast majority of my participants being Caucasian women, and all were Caucasian in general. The questionnaire itself has some limitations, as participants, it's self-reported, which relies on their own recall abilities, could also be impacted by a social desirability biases. And then an unexpected limitation, which in Montana should be a little bit expected, was the impact the weather had. If it was below 20 below on the day of class, then, or on the day of a scheduled class, then we would postpone that week and just pick up the following week. And so this happened 3 different times, which pushed our final course, our final 7th week of the project actually out an additional 3 weeks. And so a lot of our participants are rather busy, and had scheduled conflicts. By pushing out that much, they weren't able to complete the entire project, which then impacted my sample size. And so the findings of my project mirror the literature. The results are consistent with national evidence that a structured community-based program such as Stepping On is impactful for your community in reducing falls and maintaining independence. Not only are these people not falling, but they have the confidence to go out and do the things that they want to do and that they've been able to do for decades. And so that was super exciting to see. And so Stepping On, it just consistently has a positive impact on participants as well as communities. The reported improvement in confidence, there were clinically significant fall behavior changes, and then again that reduction in fear of falling. An unexpected finding also was just this reduced reported loneliness in this population, which was really exciting to see, especially given this was during the early spring, late winter in Montana, and so people can kind of get a little blue just from not seeing the sun for 3 months. But biggest part too is this just continues to reinforce the value in community-based interventions and how our public health can impact our acute care health as well. If we're having to spend less time tied up in these traumas related to falls, we can utilize resources elsewhere, and these people aren't in the hospital with a broken hip from falling. The way this has implications for practice, especially for the advanced practice nurse, is the advanced practice nurse plays a huge role in community health. Regardless of where you work, all health is community health. All community health problems are going to affect you no matter where you are working. Again, my example of we prevent these falls in the first place, we're not having to take care of them in the ICU after they fell and broke their femur. Practice implications also include the need to be proactive in our fall risk screening in older adults and referring them to these fall prevention programs. During our recruitment, a lot of the reported recruitment was just from word of mouth, or participants had taken another class at the aging services, which then is another impact on our data because these are people who are already motivated to get better, might already kind of be a little bit stronger because they've taken fall prevention classes previously, and only a few had reported being referred to by their primary care provider, which is wild because this is also covered by a majority of insurances. So we can refer them as advanced nurse practitioners. And then we need to have integration with community-based programs for our routine preventative care, collaborating between healthcare systems and public health agencies such as aging services or your community health department or your local senior center, and finding out what classes they offer. Something that I learned through this is Meals on Wheels. Obviously we've heard about Meals on Wheels, but they can provide meals even throughout the weekend for some of our participants. or if anything, it's somebody just kind of dropping by to check in on them, make sure that they hadn't fallen the night before. I also learned about other aging services that can help promote independence and keep people at home longer than I was able to implement during my own clinicals, and actually kind of help advocate for patients like, oh, you don't actually need to go to even TCU, rehab, swing bed, what have you. We can have someone from aging services come into your home and help you do your dishes, do your laundry, because that's what's impeding your discharge. Prevention is the best treatment. And then again, you can learn so much from that collaboration about what is out there and what we can offer to our patients. Stepping On has a significant return on investment. The National Council of Aging actually found that Stepping On has a 64% return on investment, which is significant, especially when we have a healthcare system that promotes cutting costs and saving money. And so, in conclusion, this project again further demonstrates that Stepping On is clinically meaningful for aging adults, which means it's clinically meaningful for all of our communities. The program has been vetted for over 20 years after it began in 2004 with Swan and Clemson. There's consistently positive results, and this is hugely impactful for participants. The program is feasible. It was rather easy to implement. Again, there is a pretty rigorous training process to be an implementer of this project. Once you go through that training process and you're able to do this locally, they provide manuals for you, they provide handouts, and then you're able to collaborate with professionals to come in and talk again about vision care. Pharmacy comes in and talks about medications. It's cost effective, right? That's 64% return on investment. The cost per participant was a little over $200, with majority of that being covered by like Medicare, Medicaid. And then it promotes health in our continuous aging population, especially as we continue to see the baby boomer generation coming to age. Right, we're on the tail end of them turning 65, and so preventing our falls, preventing their hospitalizations, maintaining their health is going to be beneficial for everybody. And then I would like to thank all of you for your interest in my project. I hope everyone's as excited about promoting health in our aging folks as I am. And then here are all of my references that I used throughout this project. And if you have any questions, please don't hesitate to reach out. Thank you.